Today, we're diving into atopic dermatitis, which you might know by its common name, eczema. This is a chronic, inflammatory allergic skin disorder that develops in people who are genetically predisposed and triggered by environmental factors. About 7% of adults in the United States are affected, and more than half of these individuals also deal with asthma, allergic rhinitis, or food allergies. Atopic dermatitis is classified as a Type I immediate hypersensitivity disorder. It involves IgE antibodies and results in dry, itchy, hypersensitive skin. The typical presentation begins with small, red, pruritic papules. Scratching these papules creates excoriated areas and fuels what we call the itch-scratch cycle. The more the skin is scratched, the more irritated and inflamed it becomes, and over time, this can cause thickened, lichenified skin with fissures. It's common to see lesions in different stages at the same time, and in adults, the hands, wrists, elbows, knees, ankles, face, and neck are the most frequently affected areas. One of the underlying problems in atopic dermatitis is a leaky skin barrier. The skin loses water, dries out, and becomes hypersensitive. Everyday exposures such as soaps, detergents, dust mites, pollen, animal dander, and even some bacteria can further break down this barrier and trigger flares. There's also a strong genetic link. Many patients have defects in the filaggrin gene located at chromosome 1q213. Filaggrin is a protein produced by keratinocytes that's essential for maintaining the skin's barrier function. Research continues to explore other genes and mechanisms, but filaggrin mutations are a well-known risk factor. Nurses should also understand the concept of the atopic march. This describes the natural progression of allergic diseases from infancy into childhood. It often starts with atopic dermatitis and then progresses to IgE-mediated food allergies, asthma, and allergic rhinitis. The atopic march highlights how genetics, environmental exposure, and immune system responses all interact over time. Diagnosis of atopic dermatitis is largely based on a detailed history, the morphology and distribution of lesions, and associated clinical features. In some cases, lab tests, patch testing, or a skin biopsy may be needed to rule out other conditions. Now let's turn to management. The goals of treatment are to avoid irritants, control inflammation, and keep the skin hydrated. Patients should be educated to avoid triggers like excessive bathing without moisturization, very low humidity environments, overheating, exposure to detergents or solvents, and common allergens like fragrances and nickel. Topical corticosteroids remain the mainstay of therapy. For mild cases, over-the-counter steroids may be enough, but moderate cases often require more potent agents such as fluocinolone, triamcinolone, or betamethasone. These are effective but should not be used on the face because they can cause skin atrophy. Instead, topical calcineurin inhibitors such as tacrolimus and pimecrolimus are used for facial lesions because they are non-steroidal immunomodulators. For severe flare-ups, short courses of systemic corticosteroids may be prescribed. Another important therapy is dupilumab, an interleukin-4 and interleukin-13 receptor antagonist. This biologic medication is approved for patients aged 12 and older with moderate to severe atopic dermatitis that is not controlled with topical therapy. Infection is also a concern. Patients with atopic dermatitis are frequently colonized with Staphylococcus aureus, and secondary bacterial infection is common. When purulence or honey-colored crusts are present, antibiotics are indicated to clear the infection. Now let's focus on nursing management. Patients and families often need guidance and support to cope with this chronic condition. The visible skin changes can affect self-esteem, social interactions, and quality of life. Nurses play a key role in teaching preventive measures and helping integrate treatments into daily routines. Skin hydration is critical. Thick emollient creams, especially those containing glycerol or urea, should be applied regularly. A warm bath with mild soap, followed immediately by moisturizer, is recommended. Short showers followed by emollients are also effective. Patients should be advised to wear cotton fabrics, wash clothes with mild detergents, and use humidifiers during dry winter months. Antihistamines, such as diphenhydramine, may be used to help with itching, especially at bedtime, but patients should be cautioned about the sedating effects. Finally, nurses should educate patients about the signs of secondary infection and stress the importance of seeking treatment if symptoms appear. Patients also need to be informed about potential side effects of their medications, especially when using corticosteroids long-term. To summarize, atopic dermatitis, or eczema, is a chronic allergic skin condition driven by genetics, environment, and immune dysfunction. It is closely linked to the atopic march, and its management requires a comprehensive plan that includes avoidance of triggers, skin hydration, appropriate medications, and patient education. With effective treatment and support, patients can improve their symptoms, protect their skin barrier, and enhance their quality of life. That concludes our lecture on atopic dermatitis.